Yes, so I had an opportunity to discuss the TROPION-Breast02 from Asian perspective during ESMO Asia this year. As a TROPION-Breast02 Asian substudy is not available, just that was just presented ESMO in October. I just analyzed the existing data to discuss whether there are differences in efficacy and toxicity based on the ethnicity ratio disparity and discuss it in this context. As you know, the TROPION-Breast02 is a randomized Phase III open-label global trial evaluating the Dato-DXd versus investigator choice of chemotherapy as first-line metastatic triple-negative breast cancer in patients for whom PD-1 or PD-L1 immunotherapy was not an option. A dual primary endpoint was met. That was reported at ESMO, PFS by Beaker and overall survival. Looking at the demographic, 47% is Asian. So they're looking at the subgroup analysis, PFS and overall survival, subgroup analysis, better hazard ratio was observed in Asian as compared to non-Asian. So because this finding, it raises another question. So are there differences in efficacy by ethnicity or race? How this fits in the evolving ADC landscapes? Looking at another TROP2 ADC, such as govitecan, ASCENT-03, that ASCENT-4 Asian population just 20%. In ASCENT-03, ASCENT-04 did not include Asian subgroup analysis data in clinical design. Other trials, such as govitecan, the ASCENT trial in metastatic setting, second line or later line, 4% are Asian. And EVO 132001 is all Asian cohort, but there's no difference. TROPION-02 Asian population showed better efficacy, but another TROP2 agent such as govitecan, similar efficacy. What about the TDXD? TDXD, DESTINY-04, the Asian population is 40%. The hazard ratio seems to be better. PFS hazard ratio 0.38 and versus 0.50 in overall population. But this zero study, the Asian population is increased up to 59%, but hazard ratio is almost similar. So Asian population do not guarantee increase of the favorable hazard ratio. So we should be cautious to interpret the results based on the ethnicity. But previous data, is a racial disparity in chemosensitive affected survival in early TNBC. That was reported JAMA Network Open 2023 journal. And also the KEYNOTE-355 and the KEYNOTE-522 subgroup analysis that immunotherapy benefit is better in Asian TNBC population. So why is that so? The Asian investigators explored that reason. So multi-omic profiling in Asian breast cancers demonstrated a higher PD-L1 and lower TGF-beta and immune score is higher in Asian population. That may be related to the better efficacy in Asian population when immune checkpoint is administered. And also molecular characteristics is somewhat different. So higher prevalence of luminal androgen receptor subtype and the PIX3 mutation is higher in Asian population. That as compared with TCGA, this could be the efficacy difference according to ethnicity. And TROP2 expression, the high versus low proportion is almost similar. That was similar in a center trial versus OptiTROP2 Breast01 study, which is done in Chinese group. As you know, different ADC has a unique and common AEs. So the question here is, are there differences in safety, toxicity profile by ethnicity? TROPION-Breast02, the key treatment-related AEs, stomatitis and neutropenia and nausea. In contrast, Center 03, the sacituzumab and the higher neutropenia, diarrhea was observed. That underscored that the toxicity profile could differ across the ADC. That is a matter for selection. So toxicity may vary as ethnicity in that high incidence of a TDX-ILD was observed in Japanese patients, and also there's a UGT1 variation that may contribute to AE differences. So when TROP2 TDXD TROPION-Breast02 was reported, Ascent 03 study was also reported in ESMO. So key practical issue in this setting is how to choose between two different ADCs. So similar efficacy, but toxicity profile is different. The administration schedule is different. Patient's preference also important. What regimen we choose. So my top topic lecture was that a discussion was summarized like this: Dato-DXd significantly improved the survival in first-line TNBC who are not candidates for PD-1 inhibitor. At least the TROP2 Dato-DXd, the benefit is consistent in Asian population, and toxicity profile may differ, but safety consideration will be important in treatment selection. That was I discussed in the ESMO Asia highlight session.